Hello everybody, this is Alexander Damron. Some of you may have seen some of my videos before or some of my cases that I post on Twitter, but I'm primarily a breast pathologist. I did my residency training at Baylor College of Medicine, followed by a fellowship in breast pathology, multidisciplinary approach at the University of Pennsylvania. So in this video, we're going to talk about fibroepithelial lesions, and I'm really going to focus on kind of the gray zones in this diagnosis, specifically on core biopsy where it becomes challenging. Do I call this a fibradnoma, cellular fibradnoma, or potentially a cellular fibroepithelial lesion that may need excision, right? So we're going to kind of touch on those gray zones to hopefully give you my systematic approach to these lesions, particularly on core biopsy, where I think they're the most challenging. And then we'll also go over kind of some gray zones in the Phyllodes family, right? When we go from benign to borderline to malignant. And I'm really going to kind of focus on those in-between areas when you're kind of, you're struggling a little bit. You're thinking, is it enough or is it not enough? Things like that actually can become tricky. You learn breast pathology and you learn fibradnomas, and those tend to be easy lesions, and then you start signing out cases, and then you find yourself in this position where you're on that fence of, do I think this needs to be excised? And that's ultimately the question, is does this lesion need to be excised? So hopefully in this video we can cover all those things, make it a little bit easier for you as we kind of see these cases in the future. So let's get started. So when we talk about fibroepithelial lesions in the breast, we're really referring to fibradnomatoid changes, fibradnomas, and phyllodes tumors, right? And if we leave fibradnomatoid changes out, because we're really considering fibradnomatoid changes more of a hyperplasia than it really is a neoplastic change, then we're talking about the continuum of fibradnomas all the way to malignant phyllodes tumors. And we want to kind of consider this a continuum of similar entities, right? And depending on where you fall on this line can change your diagnosis. As you progress up from a fibradnoma, you may call it a cellular fibradnoma when the stromal gets to look a little more cellular. A little bit up from that, you may call it a benign phyllodes tumor, and then a borderline phyllodes tumor, all the way to a malignant phyllodes tumor. Now, it's no surprise that all of these actually are kind of in the realm of the same disease, because what we have found is these fibroepithelial lesions all share the same MED12 mutation. In fact, benign fibradnomas, up to 60% of benign fibradnomas have shown to have this mutation. So we know that this is all kind of in the realm of the same entity. And basically, I like to think of this as a continuum, and you have to decide where on this continuum your particular entity lies. And one of the things to keep in mind as you're looking at these lesions, right, is fibradnomas are very common. It's the most common stromal lesion in the breast, the most common benign mass in the breast. So you're going to see a lot of these. Whereas a malignant phyllodes tumor is pretty rare. Relatively speaking, these are uncommon, right? They're not extremely rare. They're not zebras, so to speak, but they are not as common as a fibradnoma or even a cellular fibradnoma or even a benign phyllodes tumor. But once you get into these more uncommon realms, these are things that you're going to see less likely, especially if you're not a breast pathologist. If you're just a practicing pathologist, general surgical pathologist, these are things that you're not going to encounter very often, and hopefully as we go through this, I'll make it a little bit easier for you, give you some steps and approaches to these so that you feel a little bit more comfortable when you do see these cases. So one of the things that we're mainly going to be focused on during this lecture is kind of the gray zone that exists along this continuum, and these are where things can get a little bit challenging, especially on core biopsy, because the treatment becomes different, right? If you call something a cellular fibradnoma or a fibradnoma, then generally it's not going to be needing excision, right? But if you call something that is potentially a phyllodes tumor, right, then it needs to be excised. And that gray zone kind of is right here, right, especially on core biopsy. When am I safe to say this is most likely a fibradnoma, or when am I safe to say it's probably a cellular fibradnoma, or when am I worried that it could be a phyllodes tumor, in which case I would like to call this a cellular fibroepithelial lesion and recommend excision. So we're going to kind of focus on that gray zone, and then also the gray zone over here, right? Generally speaking, when phyllodes tumors are malignant or highly malignant, those are relatively easier than between the benign, borderline, and the subtle changes between a borderline and a malignant, right? When things are overtly malignant, that's not too challenging, but sometimes there is a gray zone here of when is it enough to be a borderline, and what are the criteria that we use in order to evaluate these tumors. And that's really where we're going to spend a lot of time in this lecture. Now, I'm not going to go over the normal histology of the breast in this lecture. This was just pulled out of my board review, but I just wanted to bring this to your attention because really what we're dealing with in fibroepithelial lesions is the intralobular stroma, okay? And this is within the lobule itself. And this area is generally looser and more cellular compared to the interlobular stroma, which occupies the majority of the breast volume, and this is between the lobules itself. But it's the intralobular stroma that is going to give rise to the fibroepithelial lesions. So if we look back at the embryologic development of the breast, it's very interesting because the stroma is actually the first tissue to specialize, and as that specializes, it induces the overlying epithelium to grow downward and form large ductal structures. And in fact, the lobules aren't even present at that time. You start to see those later in puberty and things like that. But for the purposes of this lecture, what's interesting to know is that it's the stroma that induces that growth. So it's no surprise that abnormal growth of that intralobular stroma is often accompanied by proliferation of epithelial cells. You'll see at least usual ductal hyperplasia in these lesions, and hence the term fibroepithelial lesion. So let's go into our first part of this, and that's just a benign fibradnoma. We know this is the most common benign neoplasm. One of the things to think about it, this is usually in younger women, and often because it's in younger women, these most often are not found as mammographic or radiographic lesions. They're actually mostly found by palpation, right? The patient comes in, she's younger, she's 27, she says, oh, I have this, palpable mass, and, what is this? And they're generally solid, they're kind of mobile, they can be firm and slowly growing. If they are found radiologically, they're going to be a circumscribed mass. Sometimes they can be slightly irregular if they're hyalinized or say they're myxoid with pushing borders, but generally they're going to be a nice, well circumscribed mass. And sometimes they can actually present as calcifications, especially in older ladies that have hyalinized fibradnomas with stromal calcifications. Even if they're smaller, say they're kind of microscopic sized fibradnomas with stromal hyalinization and calcification, sometimes you can see them present that way as well. These can usually be diagnosed on core needle biopsy, and they're going to be stable in size and they don't need excision. So let's start progressing down our continuum of fibroepithelial lesions, and that's first going to bring us to a fibradnoma, right? The most benign, common thing you're going to see in the breast realm, very easy to diagnose, generally speaking, right? And it's a proliferation of those intralobular stromal cells with benign epithelium. And you can appreciate that this, even on core biopsy, is obviously a mass. This is a lesion. You can see this is a dense nodular proliferation here. And this is a typical picture for a fibradnoma, right? The stroma is not very cellular. The proliferation is not even really that much. It's kind of dense, right? This is pretty classic case of just a benign fibradnoma. Now, there's typically two different patterns that you can see. One is the pericanalicular pattern, but one of the things that you can take note of is appreciate the sharp delineation of this lesion from the surrounding breast tissue, right? It's nice and well circumscribed, very nice and easy delineated, it's well circumscribed. And if you look again, you have this proliferation of the intralobular stroma, but in the pericanalicular pattern, what that means is that the glandular component is benign and it's not altered or distorted at all. It just looks like nice open glands within this fibradnoma. And again, another example of the pericanalicular pattern of a fibradnoma, you can see the glands are nice and open. They've got two cell layers. You can see a proliferation of the intralobular stroma. You should be able to appreciate that this is lesional tissue and not normal breast tissue, right? You can say, okay, this looks like a duct. It's a little bit altered and distorted, but overall, this is the pericanalicular pattern again, benign, nothing worrisome. You could safely sign this out as a fibradnoma. The other pattern that you can see in fibradnomas sometimes is the intracanalicular pattern, and this is where the stromal proliferation of the intralobular stromal cells tends to start, altering or distorting the benign epithelium. Maybe a little bit of UDH in this, but right here, not much, but it's clearly benign, nice and well circumscribed, well delineated from the surrounding tissue. But you say, oh, this is kind of distorted. It'll catch your eye because you think about that leaf-like pattern in phyllodes tumors, but again, the stromal cellularity is not there, right? And we're going to go over a lot of different features to help you out when we're going over these, but you could safely call this a fibradnoma on biopsy. And taking a closer look at that, some of those features that we're going to talk about, and we're going to go over all this in detail, okay? But one of the things that you don't see subepithelial condensation. The stromal cellularity is relatively low, and it's relatively uniform in that intralobular stroma, right? And you don't have condensation, you don't have stromal atypia, you don't have increased stromal mitoses. The epithelium is nice and benign, again, well delineated. These are good features of a benign fibradnoma, just has an intracanalicular pattern that's giving you that distorted and altered, benign epithelial look. So let's progress up on the continuum just a little bit, and let's take a look at this lesion here. What we notice here is that, again, the glands are open. Look, it's a little bit hyperplastic, but you have a nice benign myopithelial cell layer, clearly benign, ducts here, glandular component. And if you look at the stroma, it's, a little bit gray, right? It's a little bit myxoid, and it seems to be a little bit more cellular than on our previous case. But what do we notice about this is that, again, there's no subepithelial condensation. And what I mean by that is that the stromal cellularity is not condensing, aka looking more cellular just beneath the epithelium, but it looks relatively uniform throughout this. It's not distorting our glands. There's no stromal atypia. Again, no stromal mitoses. So if you take a look at higher power, you can see, again, the cellularity is relatively low. These are nice, benign, clearly benign stromal cells, no mitoses, no real atypia. Again, no subepithelial condensation. It's just a little bit myxoid. It is a little bit more cellular, but not really that bad. So this is something that I would sign out as a partially myxoid and slightly cellular fibroadenoma. You're safe to watch this. Obviously, the patient's going to come back in 6 months or so, make sure it's not growing or anything like that. But on biopsy, I don't think you have enough to necessarily get this excised yet. So let's again progress up this continuum just a little bit further now. And what do we notice here is that, again, the stroma is actually quite cellular, right? We notice that the cellularity of this lesion is pretty relatively increased to those first kind of fibroadenomas that I showed you. And it'll certainly catch your eye. You definitely want to go down when you see this kind of cellularity in a fibroepithelial lesion. But let's take a look at all the benign stuff, right? We have nice benign epithelium, nice 2-cell layers. The glands are nice and open. They're not being distorted or compressed by the stroma, and the stroma itself is actually, again, relatively uniform. The increased stromal cellularity in this lesion is relatively uniform throughout this slide. It's not condensing up against the epithelium. It's not really, creating any atypical features like infiltration or mitoses or necrosis, anything like that. But you definitely want to look at something like this on higher power. Look at that stroma, and if you see here, it's all, again, relatively uniform. There's really no mitoses. There's no significant stromal atypia. The epithelial component is clearly nice and benign. You could say, oh, there's a little bit of proliferation, but it has a nice myoepithelial cell layer around these, glandular components that are clearly benign. So this is something that you could safely call a cellular fibroadenoma. Now, keep in mind on core biopsy, our job is not to cause surgery. Our job is to prevent surgery. They're taking a minimal amount of a tissue from these patients to say, hey, does this need to be excised? And when you look at this, just because there's some increased stromal cellularity doesn't really necessarily mean it's enough to call it a cellular fibroepithelial lesion and warrant excision. You have to say, okay, it has increased stromal cellularity, but it doesn't have any atypical features. It's all benign appearing. You could safely call this a cellular fibroadenoma and let them watch this lesion radiologically. Let's take a look at another example. Again, you're going to get this case as a well-circumscribed mass. Hopefully you get the clinical history of whether or not it's rapidly growing, but let's say, for instance, you don't, and this is what you get. Again, you have a nice increased stromal cellularity in this case. It's not too high, right? It's not overtly cellular that it's just going to blow you away, but it's certainly increased a little bit from your typical fibroadenomas in older patients. Now, if this was a younger patient, in her teenage years, early 20s, this is actually the stromal cellularity that you might expect in a normal fibroadenoma. But anyway, this stromal cellularity is relatively uniform. Again, no subepithelial condensation. You don't have any really atypical stromal features, no mitoses, no infiltrative borders. And taking a closer look at this on higher power, really no mitotic activity. You can see nice benign epithelial component without significant subepithelial condensation. Again, this would represent a good example of something you could safely call a benign cellular fibroadenoma on core biopsy. So let's take a step back here just a moment and talk about fibroadenomas as we're kind of progressing up this continuum. Again, it is the most common benign neoplasm in the breast and will most often present as a well-circumscribed palpable or mobile mass. This is a biphasic tumor consisting of that intralobular stromal proliferation with benign epithelial cells that sometimes can show proliferation as well. This is an example of a more hyalinized fibroadenoma. Typically, you're going to see these in older patients where these fibroadenomas have hyalinized. Sometimes they'll have calcifications in the stroma, but you can see these in younger women as well. Fibroadenomas themselves typically are going to present in the younger age range of women between 20 and 35 years. However, we know that these show the same MED12 somatic mutations as phyllodes tumors. So it's really, again, a continuum of a disease process. So if we look at the cases we just looked at that say, oh, you could safely call these a cellular fibroadenoma, Now we're going to get into the gray zone. Now on core biopsy, differentiating between a cellular fibroadenoma and a benign phyllodes tumor can sometimes be very difficult on a core biopsy. And when you get into that gray zone, how do we approach that? One of the things that you want to think about, and hopefully you're going to get this as clinical history, is it growing? How big is it? How fast is it growing, right? Sometimes people say, oh, it's rapidly growing and it's been, 0.2 centimeter growth in like 6 months. That's not rapid, but if they say rapid growth and it's 4.5 centimeters and it was 1.5 centimeters 6 months before that, that's rapid, right? So the clinical information is very important. So let's look at a few cases that are going to fall along that continuum and see how we would approach those. So let's take a look at this case. This case here clearly has increased stroma, okay? Now we're starting to have this distorted glandular pattern, right? The compressed benign epithelium, which is clearly benign, but you can see here we have certainly increased stromal cellularity. It's not overtly cellular again. It's not blowing you away, but it's certainly increased. And one of the things that we can notice as we're kind of looking at the borders of the stromal cellularity, okay, if you look right here, it's starting to become a little bit more cellular as we're approaching that epithelium. And it's a very subtle in this case. This is a very subtle subepithelial condensation. And if we look in other areas, again, this is the same biopsy. Hopefully you can appreciate that on low power. Again, if you look at low power, I think it looks a little bit more cellular right underneath that epithelium as compared to the stroma in the middle of these kind of proliferative areas, right? So you can appreciate that. That's what's called subepithelial condensation. And when you see that, that's something that should alert you and say, okay, and again, we're talking about core biopsies, okay? That's something that should alert you to say, you know what, maybe we should take this out. So now you're on alert a little bit and we're going to go higher power. And so what do you not see? You don't see stromal mitoses, right? You don't see really atypia. The epithelium is nice and benign with its 2 cell layers. But again, you do have that subtle subepithelial condensation. To me, this is enough to warrant the diagnosis of cellular fibroepithelial lesion. So when you say cellular fibroepithelial lesion, now you have bought that patient an excision. One of the things that you shouldn't do is diagnose phyllodes tumor on core biopsy. You should never say, oh, this is most likely a benign phyllodes tumor. Just call it a cellular fibroepithelial lesion and give a differential diagnosis in your comments. Say, this may represent sampling of a cellular fibroadenoma versus a phyllodes tumor. Definitive classification should be made at the time of excision, because on biopsy, one, we know that phyllodes tumors show morphologic heterogeneity. I could show you a phyllodes tumor, and which I will, where areas look totally benign, other areas could be malignant. So you don't want to kind of jump the gun on these diagnoses on biopsy. Your job on the biopsy is to say, this is a cellular fibroepithelial lesion, aka this is something in the fibroepithelial lesion family that I think needs to come out so I can better assess this entire tumor and then place it in its correct diagnosis. So let's take a look at another example. So this is again a fibroepithelial lesion. You can see looks like some little cysts inside of it. We have a lot of usual ductal hyperplasia, but you can see the stromal cellularity here is a little bit increased. It doesn't have that subepithelial condensation that we saw in the last case, and the stroma, at least on lower power, doesn't look quite atypical. However, when you get to the periphery of this particular lesion, what you notice is that's a little bit infiltrative, okay? It's starting to, it's not really well delineated like the previous fibroadenomas that we had seen, okay? So this is an example of what you would call infiltrating borders if this was an excision and you said, okay, this is an excisional specimen, I've got this, and you've looked at the whole thing and the edges look like this. This is the infiltrative borders, right? But keep in mind, we're dealing with the core biopsy right now. So you're going to get this on core biopsy. Even if this has well circumscribed mass, it may say slightly irregular borders, something like that, and you start seeing this infiltrative borders as you're looking around the case, it should certainly grab your attention. Again, you can appreciate that this is the cellular fibroepithelial lesion. We have some kind of micropapillary hyperplasia here. This is all UDH. Nothing was outright atypical, but again, if you looked at the edge, it wasn't really delineated where this lesion was stopping. You could see it's kind of starting to infiltrate out into the surrounding adipose tissue. On higher power, you can appreciate that as well. Again, this is all UDH, but our stromal kind of proliferation is infiltrating at the edges. Again, that is enough to warrant the diagnosis of cellular fibroepithelial lesion and get this excised. Now, we're going to go over the adverse features of phyllodes tumors later, and infiltrative borders is actually an adverse feature that would start pushing us up into the borderline category. But even with that said, okay, even with that said, we're still dealing with the core biopsy. You do not need to jump the gun because you don't have the the entire lesion to assess for other things yet. You still don't need to pull the trigger and say, oh, this is a borderline Phyllodes tumor on the biopsy. Again, call it a cellular fibroepithelial lesion, leave your comment, describe it. The overall stromal cellularity is increased. It's relatively uniform without subepithelial condensation. However, the lesion appears to show infiltrative borders on the specimen of the core biopsy, however you want to word that, right? And by saying that, you're describing it, so when it becomes excised, now you can read it, or wherever the patient gets excised, they know what you were looking at and give your differential at that point. This may represent sampling of a Phyllodes tumor, and definitive classification should be made at the time of excision. So now you've said, okay, there's atypical features. This is probably concerning for a Phyllodes, but your final diagnosis does not need to say Phyllodes tumor on core biopsy yet. Let's look at the whole thing first, and on core biopsy, let's call this a cellular fibroepithelial lesion. Let's take a look at another example here. So then, this is clearly sampling of a fibroepithelial lesion. It has a loose kind of myxoid stroma. The cellularity is not too much here, right? It's relatively low. You've got nice open glands, no significant subepithelial condensation. I think most of you could look at this and safely and comfortably and confidently call this a fibradnoma. And looking at higher power, again, nothing would deter you from that diagnosis. It does have a myxoid stroma. It could be, a myxoid fibradnoma, but the cellularity is not atypical. Again, no subepithelial condensation, no mitoses, no necrosis, no infiltrative borders on these parts. But then you look at some of the surrounding tissue, okay? You see some of the surrounding tissue in this case, right? So you have that nice core of a fibradnoma, but then you look over here. Now, what is this? Is this an infiltrative border? And this is where things can become a little bit tricky, because sometimes patients that have fibradnomas have background fibradnomatoid change, all right? So we clearly have a benign fibradnoma, and this really isn't part of that lesion. This is not the same fibradnoma that's infiltrating out into the fat. This is actually background fibradnomatoid changes in the breast, okay? So whereas our last case, you could clearly say, okay, this is the lesion itself, and as we get to the edge of that lesion, it's extending out into the fat. I'm worried, let's get this taken out. This is different. This case has clearly a benign fibradnoma, and in separate cores, we have this hyperplastic fibradnomatoid change. So this is an infiltration of that same lesion. So this is where you got to be a little bit careful, because in this case, you could safely call this a fibradnoma and surrounding breast tissue with fibradnomatoid changes, and this doesn't necessarily need to be excised. So again, let's start progressing up this continuum a little bit more. I think on this power here, you can already kind of say, oh, this has leaf-like architecture, right? That's where that Phyllodes tumor, diagnosis comes from, this leaf-like architecture. And even on low power, you can see it has clearly some subepithelial condensation. You can appreciate that. Let me put this pointer out of the way and look right there at that subepithelial condensation, right? A little bit looser here, a little bit more condensed here. Same down here. We can see a little bit of condensation pushing up this benign epithelium and giving it that leaf-like architecture. And taking a closer look at that stroma, again, some areas are relatively uniform. It's not super condensed right here, maybe a little bit right here. But the stroma itself is not atypical, right? No stromal mitoses, no significant sarcomatous stroma or stromal atypia, no infiltrative borders. But again, you do have that leaf-like architecture. And if you look in other areas, something should be catching your eye, right? What's going on here? It's not atypical, right? It's not like overtly atypical. The subepithelial condensation is not crazy, but it is increased. But what do you see? Mitotic activity, right? You see mitotic activity in the stroma. So there's 2 mitoses in 1 high power field on the core biopsy. That's plenty. Even without the mitoses, with that leaf-like architecture and that subepithelial condensation that we saw, again, that's a case where you would say cellular fibroepithelial lesion as well. But let's say that subepithelial condensation wasn't there and you still saw these mitoses. That's also enough to say, hey, this is a cellular fibroepithelial lesion. Let's get this out. You got 2 mitoses in 1 high power field. Again, we'll create a comment on these cases. You don't have to diagnose this outright, but say, hey, this is a cellular fibroepithelial lesion with a leaf-like architecture and areas of subtle subepithelial condensation. While the cellularity is relatively uniform and relatively low, it's not crazily increased, right? There are areas of increased stromal mitotic activity. Say it like that, and then say, we need to get this excised and better classify this at the time of excision. So the thing about differentiating between, really we'll say cellular fibroadenoma and a phyllodes on biopsy can be extremely challenging and sometimes impossible, right? And I think that it's better to use the terminology cellular fibroepithelial lesion, which is something that the surgeons will excise. So if you're concerned that this is possibly a phyllodes tumor, then that's the terminology that you use. And I've shown you a few examples and scenarios of things that I look for to kind of push me into that category, okay? Now, there's two schools of thought here. If you're on that kind of fence, okay, and it's not overtly concerning, right? It's not something that I showed you has infiltrative borders, increased stromal mitoses, clearly subepithelial condensation with leaf-like architecture. Let's say it doesn't have all that, but let's say it has pretty increased stromal cellularity. You kind of says, wow, this stroma is highly cellular. But it's not atypical. I think this is a fibroadenoma. There's two schools of thought. Some people have a lower threshold. Maybe they're worried a little bit. They'll call these a cellular fibroepithelial lesion. The problem with that is you've already bought that patient a surgical excision. The best way to differentiate whether something is a cellular fibroadenoma versus a benign phyllodes tumor is rapid growth over a short interval of, say, 6 months. So the other school of thought is say, well, let's call this a cellular fibroadenoma, and you can leave a comment and you can describe it. You can say that there's no atypical features, and then you could say, close clinical follow-up is, recommended to look for rapid interval growth. Put that in your description. And if it grows rapidly over a short period of time, then excise it. And if it's a benign phyllodes at that time, that's okay. One of the things is you've given them time to potentially not have surgery. And most of the times you're going to be right? But if it doesn't grow, same lesion doesn't grow, then they don't need surgery and they can continue to follow it. So without really adverse features or something that really pushes you into the cellular fibroepithelial lesion, sometimes it's better to back off and leave a comment saying, while the stroma shows increased stromal cellularity, then give your pertinent negatives. No significant stromal mitoses, no atypia, no significant subepithelial condensation is seen. This most likely represents a cellular fibroadenoma. However, close clinical follow-up for rapid interval growth is recommended. Right? And if you take it out at that time, say in 6 months it grows by half a centimeter, go ahead and take it out. Now, if it's a cellular fibroadenoma and it's 3.5 centimeters, the patient may want it out anyway just for cosmetic reasons, right? But that still doesn't give you the right to kind of overcall things on the core biopsy. So let's look at a case, and I want to demonstrate the importance of that clinical history, okay? So this is a core biopsy that I received, and this is what you get, right? And if you look at this case, this is not really that cellular, okay? The stromal cellularity certainly increased. You clearly have, proliferation of the intralobular stromal cells with this benign epithelium, right? It's surrounding this benign epithelium. There's no significant mitoses. There's no real, atypia in this stroma. The epithelium's clearly benign. I think the vast majority of people would safely call this a fibroadenoma or a cellular fibroadenoma, and I think you would be right. So if you got this case and you had no clinical history, I think you would be totally in the right to refer to this as a fibroadenoma and sign it out. And I think no one would disagree with you. However, let's say you get the history that this is a 42-year-old with a 4.5 centimeter rapidly enlarging mass. Okay, does that change your approach at all? Well, histologically, I think this is probably a fibroadenoma just looking at these slides, looking at the pieces that have been sampled. But it's 4.5 centimeters. Do I have everything? And if you have this history, that's something that you really need to think about, because phyllodes tumors can show really a lot of heterogeneity within the lesion itself. I could show you a malignant phyllodes tumor where areas of it look like a benign hyalinized fibranoma, right? So that's something that you need to think about when looking at these lesions. So in this particular case, with that history, I decided to sign it out as a cellular fibroepithelial lesion, and I left quite a bit of comment, right? And so these are the comments that I'm talking about. I said, it shows a cellular fibroepithelial lesion, and I gave all of the pertinent negatives. I said that the stromal cellularity is slightly increased, but it's relatively uniform with benign open glands without subepithelial condensation. I said everything that's not there on the biopsy. So there's no mitoses, there's no atypia, necrosis, or other atypical features. But what I said is, I've got this clinical history, right? I said, although a cellular fibroadenoma is favored, right, the clinical and radiologic assessment of a rapidly enlarging mass is concerning for a possible phyllodes tumor, given that these can show morphologic heterogeneity. And basically I'm saying, with this rapidly and growing, even though what you've sampled is most likely a fibroadenoma, maybe we should take it out and see what this entire thing is. So this is that same case on excision, right? This is the excisional specimen now. And if you look right here, again, if I took a core biopsy, bang, bang right through there, I think everyone would probably say this is a benign fibroadenoma, and you'd be right. Everything was fine. Nothing really atypical here, nothing concerning. However, in that same specimen, you go over a couple fields, and you start seeing areas like this where the stromal cellularity is certainly increased, right? You're like, wow, this is actually increased stromal cellularity. There's not really much epithelium in here. This epithelium and this component of the lesion is benign, but this is certainly concerning. Now you're kind of saying, okay, I need to start taking a closer look at this and see really what we're dealing with. So you go down on higher power in some of these areas that have higher cellularity, and what do you see? All right, again, the stromal cellularity is not too increased down here, but what do you see? Mitosis, 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 mitosis. Right? There's 4 mitoses right there in one high power field. And again, we're going to go over these adverse features later, but one of the adverse features when you're grading phyllodes tumors is greater than 10 mitoses in 10 high power fields. Well, we've got 4 in 1 right here. So now we're starting to think, on the biopsy, you're saying, oh, it's benign fibroadenoma. Now I'm starting to wonder, oh my gosh, is this a phyllodes tumor that has adverse features? So then I'll look at the periphery of this lesion, right? Look at the periphery of this lesion. This is infiltrative borders on excision, right? This is actually the margin of the specimen. And in fact, some of the margins in this case, I believe, were involved, if I remember correctly. But nonetheless, this lesion doesn't have a well-delineated border. It's starting to infiltrate into the surrounding adipose tissue of the breast interlobular stroma, right? So now we have an infiltrative lesion with increased mitoses. Now we're concerned that not only is this a phyllodes tumor, but it's probably at least a borderline phyllodes tumor, right? And again, other areas showing that infiltrative border. I guess the margin was involved. I took a picture of it. So, you have this infiltrative margin of this lesion, increased stromal mitoses. Oh, and by the way, there ended up being low-grade DCIS in this case, right? This was actually one of the wildest cases I had. And if it wasn't for that clinical history, that this was rapidly enlarging, if it came with no clinical history, you would have said that's a fibroadenoma. But with that clinical history, look, now we got it excised, and it's a lot worse than what we thought. So the morphologic heterogeneity of phyllodes tumors is something to be respected. In this case, ended up being ductal carcinoma in situ involving a phyllodes tumor of the breast of borderline malignant potential. And the atypical features in that were the increased stromal mitoses. I had 14 and 10 high power fields, infiltrative borders, and there was some mild cytologic atypia, not real significant. But again, compare that to what was seen on the biopsy, right? So that's how clinical information is really important when looking at these fibroepithelial lesions that are certainly in that gray zone. And I hope that I can approve that right here. The morphologic heterogeneity, again, is something to be respected. This was actually a malignant phyllodes tumor. Okay, let's say you biopsied this over here. It's hyalinized, benign epithelium. You may actually think this is a hyalinized fibradnoma, and this is highly cellular. So depending on where your needle track goes on the biopsy, your biopsy results can be different. So it's very important that you have clinical history with these cases. Now, that shouldn't deter the way you interpret what's on the slide. What's on the slide is what's on the slide. Right? And you say what you have. So in that case, I said what was there, and I said what wasn't there, and I said, well, but what's concerning is how rapidly this is growing. So let's take this out. And then we ended up getting what we got. So what are the things that you can look for to help distinguish between a phyllodes tumor and a cellular fibroadenoma? Again, we're talking about the core biopsy, and ultimately what we're delineating in these is what needs excised and what doesn't, okay? And one is architecture. Fibroadenomas are typically going to have open glands, okay? Now, if you have that intracanalicular pattern where the glands are a little bit more distorted, obviously that is something that's going to make you think about phyllodes tumor, but generally speaking, open glands are what's going to be seen in fibroadenomas, even cellular fibroadenomas. Whenever the ducts are compressed, giving it that open quote leaf-like architecture, right? That's when you start thinking about phyllodes tumors. This is a case of benign phyllodes tumor. You can see the nice subepithelial condensation here, but the overall stromal cellularity is relatively low, but look at these nice leaf-like compressed ducts. The other thing that we want to look at when we are trying to delineate these is the stromal cellularity itself, and how is it dispersed? Well, in fibroadenomas, it's going to be relatively uniform. You can see here the stroma is relatively uniform throughout this entire picture, right? It's not really condensed up in the stroma, whereas the cellularity in a fibroepithelial lesion will tend to condense right up underneath the epithelium, and again, that's what's pushing it, giving it that compressed leaf-like structure, right? So that is something that you want to look for as well. Also, stromal overgrowth. Stromal overgrowth is defined as your 4x objective with no epithelial components, okay? You should never see that in a fibroadenoma. If you have stromal overgrowth, it's not a fibroadenoma, and typically those are only seen in higher grade phyllodes tumors. And in fact, that's going to be an adverse feature that we talk about later. So if you have stromal overgrowth, you're at least into phyllodes tumors. Another thing is stromal nuclear polymorphism, and this can be a little bit challenging in some scenarios, but for the most part, fibradnomas shouldn't have any atypia. Now, if there's inflammation for one reason or another, you may have a little bit of atypia, mild cytologic atypia, but for the most part, you shouldn't really have any stromal atypia, no significant atypia, and certainly no sarcoma to stroma. Whereas in a phyllodes tumor, typically the stroma is going to look more and more atypical the higher into that realm of phyllodes that you get, obviously with malignant phyllodes tumors having the most atypical stroma all the way to sarcomatous, right? And then in a fibradnoma, the other thing we're looking at is mitosis. Fibradnomas generally aren't going to have any mitoses. You may find one or two if you're really looking really hard, but for the most part, you shouldn't find that many. Whereas phyllodes tumors are going to have increased stromal mitoses. Now, it's adverse if there's greater than 10 in 10 high power fields, but still, let's say you find 4 in 10 high power fields. That would be unusual for a fibradnoma. And while it may not be adverse in order to push it to borderline, again, it may be a benign phyllodes. So generally speaking, you shouldn't have mitoses in fibradnomas, and as you get, again, higher into the realm of phyllodes tumors, the mitotic activity will continue to increase. The other thing that we want to look at is tumor borders. Sometimes this can be very difficult to assess on the core biopsy because you may not actually have the border of the tumor, but if you did, and again, some of those cases that I showed you, in a phyllodes tumor, it should be nice and well delineated from the surrounding tissue, nice and circumscribed. It starts, you have the fibradnoma, and then it stops, boom, benign breast tissue. Whereas in a phyllodes tumor, it typically has a lobulated look to it, okay, and you'll have kind of this bulging protrusions kind of throughout the lesion. Grossly, they look like bulbous protrusions. You have this kind of bumpy surface, and on radiology it may be like an irregular mass. You're going to have those kind of terminologies. They'll say micro or macro lobulated mass. Those are the kind of terminology words you want to look for in the radiologic description. And again, you may or may not see that histologically depending on if the edge of the lesion was sampled in the core biopsy or not. The other thing is obviously those infiltrative borders. If the border starts to infiltrate, that's an adverse feature. That's obviously in the realm of phyllodes and will help us when we grade these. So let's progress up that continuum just a little bit further. And this is a case I actually showed in my Twitter cases. So some of these are going to have my handle because I pulled them off of Twitter. I had taken pictures of these previously. But if you take a look at this on low power, you can appreciate this is a really nice leaf-like architecture, right? This is a good example of, quote, leaf-like architecture. And the stroma is actually pretty myxoid in this. But this was actually an example of a benign phyllodes tumor. But I'll go over some of those features later. But on this power, on low power, you can say, oh, well, that has a very nice leaf-like architecture. And if we look in other areas of this lesion, again, you can see that the stromal cellularity is actually relatively low, but it is kind of having this subepithelial condensation, very subtle subepithelial condensation that's compressing these ducts, that's giving it this leaf-like architecture. And this was irregular, had those kind of microlobulated borders. And these are features that are pretty typical for a benign phyllodes tumor that isn't going to have any of the adverse features that we're going to talk about in the phyllodes tumor realm. And again, looking higher power, you can see that the stromal cells themselves, they're not atypical, right? There's no real mitoses. It does have a little bit of a myxoid stroma, but again, nothing concerning here in the sense of could this be borderline or could this be malignant? Nothing concerning in those regards, but with that leaf-like architecture, the subepithelial condensation, and the microlobulated borders, and this is enough to diagnose a benign phyllodes tumor without any adverse features. So let's look at the grading criteria that I use when I'm grading a phyllodes tumor. And I think me and a lot of people in the United States use the Stanford surgical pathology criteria to grade phyllodes tumors. It's a very objective approach. And the thing about phyllodes tumor grading is it's not a universal thing, right? It's not a universal agreed upon grading system because, say, WHO comes out and says, well, to call it malignant, you have to have all the adverse features. And, that's a little bit, to me, it's a little bit much to say you have to have all of these to call it malignant. If I have a sarcoma to stroma with liposarc, and high mitosis and stromal overgrowth, but it doesn't have an infiltrative margin. Now, generally, it usually will. I'm probably still going to call it malignant, right? So I like the Stanford criteria. It gives me an objective approach to these. And I think that if you use these, you'll find yourself more objectively assessing phyllodes tumors at the time of excision. Now, remember, this is at the time of excision. You really want to grade these on excision. Now, if it's totally malignant on the biopsy, you could certainly call it a malignant spindle cell neoplasm if you wanted to, and then defer final classification to the excision, right? You got to think about even metaplastics in those scenarios. But nonetheless, if we're on that core biopsy realm of the gray zone, right, between a cellular fibroadenoma, benign phyllodes, or benign to borderline phyllodes tumor, again, call those a cellular fibroepithelial lesion on biopsy, and then we'll grade it on the excision. And the way that we're grading is we're looking for these adverse features. There's 4 adverse features that we use when we're grading phyllodes tumors. Stromal overgrowth, which is your 4x objective, right, a 40x field without any epithelial components. So it's a 4x objective with all stroma. That's considered stromal overgrowth. The next adverse feature is a high mitotic index, which is greater than 10 mitoses per 10 high power fields. Our third adverse feature is sarcomatous stroma, and our fourth being an infiltrative margin. And we've kind of touched upon all these in some of the prior biopsy cases that I've showed you, but these are the 4 adverse features now we're going to look at on the excision. Okay, and if we don't have any adverse features, if none of those are present like our previous case, right, but it's got subepithelial condensation, it's got the leaf-like architecture, it's growing rapidly, it's got lobulated margins, that's a benign phyllodes tumor. Now these have a 20% recurrence rate after local excision, which will drop to 10% if they get a centimeter margin, but generally surgeons aren't going to be getting 1 centimeter margins around these. A lot of times they're actually shelling them out, or maybe getting, a half a centimeter. It's unusual to actually get a clear full centimeter around this entire thing. So if we go up to borderline, now it's if you have only one, okay? You only need one adverse feature, but you're short of the diagnosis for malignant. So one or more of these adverse feature is going to make it a borderline phyllodes tumor. So if you have stromal overgrowth, it's borderline, right? But none of the rest. A high mitotic index, but none of the rest, it's borderline. Once you've diagnosed borderline, these tend to have a higher recurrence rate after local excision. Again, that goes down a little bit if you get a 1 centimeter margin, but again, that's unusual. And then to diagnose malignant, that's if you have a high mitotic index and a sarcomatous stroma, or you have a stromal overgrowth and either a high mitotic index or sarcomatous stroma, right? So sarcomatous stroma tends to be one of the main driving factors of a malignant phyllodes tumor, but you have to have another adverse feature on top of that to classify it as malignant. And generally, again, how is that going to change treatment? And generally speaking, the next treatment steps are going to be the same: surgical excision. Sometimes you're going to be in these tumor boards where you're going to have these really large malignant phyllodes tumors. Maybe they got malignant heterologous elements in them. I've seen discussions about, should we potentially radiate this or not? And those are generally going to be very large lesions. Again, there's no definitive recommendations for things like that. So generally, even though we have this grading system, the treatment for all these is relatively the same, right? Even benign, borderline, and malignant, the treatment is surgical excision. What changes is the relative rate of recurrence and the possibility for metastasis when you get into the malignant realm. So let's progress up the continuum just a little bit, right? I just showed you a benign phyllodes tumor previously, and now we're going to progress up just a little bit. And this is actually the case that I had showed earlier that had the, what looked like a benign fibroadenoma on biopsy. This is the same case, but again, what do you notice? You notice increased stromal cellularity. And as I pointed out earlier in the lecture, this was a case that had increased stromal mitoses, right? Here's 4 mitoses in 1 high power field. And it had infiltrative margins. So those are 2 adverse features right there, just in these 2 slides with this particular lesion. So if on excision, that's what you have, then that's enough to say this is a borderline phyllodes tumor. Now in these, I always put a comment about what adverse features were met and which ones weren't, right? So the adverse features in this case were the significant mitotic activity and the infiltrative borders. So that's something you'll say, shows a pattern typical for a phyllodes tumor with increased stromal mitoses, parentheses up to 14 per 10 high power fields, close parentheses, right? Something like that with infiltrative borders, and then you'll say no sarcomatous stroma, necrosis, or other atypical features are seen, something like that. However you want to word it, and say, these combined, features are most consistent with a borderline phyllodes tumor. So now if we progress up just a little bit from that, right, these are the cases that you're going to put down on your scope and it's going to impress you, right? You're going to put this down and you say, wow, that is increased stromal cellularity, right? This is certainly increased stromal cellularity with obvious subepithelial condensation. You can appreciate that the subepithelial stromal proliferation is certainly condensing up against this benign, compressed duct here. And then you look in other areas and you have stromal overgrowth, right? This is all stroma with no epithelial components. Even on low power, you can appreciate that these cells are pretty big. They're pretty atypical for stromal cells in the breast. And then you look higher power in these higher cellular areas and mitoses start jumping out at you, right? Again, here's a mitosis here, here's one here, here's one here, here's one here. And these are certainly atypical, right? They're big, they're plump. They almost have kind of a vesicular, chromatin pattern in some of these, but they're certainly atypical, right? They're plump spindle cells for the breast. That's unusual. And these are features of a malignant phyllodes tumor, right? So a malignant phyllodes tumor is going to have all of those adverse features, and this one had all of it, right? It had significant mitotic activity, it had stromal overgrowth, it had this atypical stroma, it even had infiltrative margins, which I didn't show you on those pictures, but it had all of the adverse features that fulfill the criteria to be called a malignant phyllodes tumor. Now again, the treatment's going to be the same. The treatment is surgical excision. There's really no rule, there's really no role for chemotherapy that we know of right now. Obviously things can change in the future, but obviously as of this current moment, there's no current recommendations to radiate these. But again, on a case-by-case basis, because these cases are so uncommon, especially if you're in a community area, maybe you're going to have discussions like, should we radiate this? Should we not? Obviously that's going to be on a patient-by-patient scenario that's best discussed on a large clinical team that involves the pathologist, involves the radiation oncologist, the radiologist, and the treating clinicians, right? That's something that may be uniform, not uniform, but discussed with a particular patient scenario. But as of right now, it's still going to be, generally speaking, just surgical excision. Other things that you can see in malignant phyllodes tumors are malignant heterologous elements, the most common of which being liposarcoma. All right, so whenever you have a malignant phyllodes, certainly keep an eye out for malignant heterologous differentiation. This is actually the same case of the malignant phyllodes I was just showing you. This case was actually wild. It had this liposarcomatous element in it, just a very malignant case. Other things that you can see, this was a case that I had showed on Twitter, again, so my handle's there in it, but this was a case I had that was a malignant phyllodes tumor that had chondrosarcoma in it. You can see that, these low power images, hypercellular, chondroid tissue here, certainly highly atypical stroma. This was an example of chondrosarcoma inside of a malignant phyllodes tumor. The same case that had malignant cartilaginous differentiation in it also had malignant bone formation or osteosarcoma inside of it. One of the things to keep in mind if you have a malignant phyllodes tumor are these osteoclast-like giant cells. If you start seeing these osteoclast-like giant cells in a malignant phyllodes tumor, keep an eye out for a malignant, bone heterologous differentiation, because, these often go hand in hand. So I hope all of you found that helpful. I put a lot of effort into making this, trying to make it practical, really talk about the gray zone areas on core biopsy. We spent a lot of time focusing on the things that I think could give you trouble, right? If you're not seeing a lot of these, right? Phyllodes tumors are not common lesions. So if you're in general practice and you don't do a lot of breast pathology, these land on your desk, not so commonly, and it's challenging. You're having to decide on core biopsy what you think needs to be excised versus what doesn't. So I hope that I gave you some kind of practical approaches that I use, and I hope that you find it helpful. I hope everyone enjoyed this. This is something I put a lot of time and effort into, so I hope that you found it helpful. So if you have any questions at all, please feel free to leave a question or comment in the comment section, and if I have time, I'll definitely try to answer that as well. You can also follow me on Twitter at @DamronMD. I do post breast cases on there every once in a while. The Don't Rush Breast series. I've posted, I think, 37 or 38 cases on there. Very interesting cases, so feel free to join in on that. And hopefully I'll see you in the next video, or hopefully I'll see you on Twitter, or maybe I'll see you in a meeting in the future or in a future lecture. So thank you, and see you next time.